the relevant places as needed.
All right, thank you. We don't have any sort of set order, but I'll just ask any board members who have questions or comments to please go ahead, and obviously don't be shy.
I can start if you like. Oh, no, go ahead.
You go ahead, Jess.
All right. I'm trying to understand the commercial rate, the commercial price increase. And I know that, from the narrative, it says 3.6% increase, but I also realize there's additional rate growth expected because of unrealized prior rate increase allowances that didn't occur. And so I'm just looking at, the tables here, and I see, if you can just turn to let me just see, think of which, yeah. So there's two places where I see commercial price. One is in the 10.2% here. And then on the other page, I see the 3.6%, which is presumably the charge master increase just for this year. And then the 8.6, which is just for this year. And I just wanted to understand, Sal, and then maybe Jen, if you want to add on to this. I'm trying to make sure that I understand what is the actual in the pocket cost of commercial, ratepayers in your community. What are they going to feel this year in terms of the commercial rate increase? Is it the 8.6? Is it just maybe if everybody could answer that. Somebody could answer that.
I'll just start by saying, so yeah, this is designed to just catch the annual from 23 to 24. And this would factor in that 1.5 million that, again, I think is an area of risk in terms of Gifford's ability to realize the full amount. So that would be the highest amount if they were to get that all in their negotiation, which
in other words, if the carriers were willing to retroactively apply previously approved rate increases,
it would be the increases this year would reflect those that have been approved in previous years, but not implemented due to the work on the charge master, as well as the EMR upgrade that they're rolling out. Is that fair, Jen? I don't want to.
It is, but I think if I could, Sarah, the total board member homes for the 1.5 million is from the 22's 3.5%, and as well as the FY23's 3.65% request that we had. Those are the dollars combined of those 2 years. This year is 3.6%, as you see on the chart here. That is $853,000. So in total, it would be 2.3 million in net that we are requesting of the commercial payers. Hopefully that helps with the tie it out.
No, it does. And in terms of the charge master increase from 2022, or the last time that it was actually updated to now, what is that going to look like?
That would be the total of 10.2 that you saw on the other chart. Okay. Between 20, this one's 23 to 24. The other percentage is 22 to 24.
Okay, that's what I thought. I just wanted to make sure it is all, everybody's on the same page about where all these moving parts are with price. Okay, and then the other area that was a bit unclear for me was in the labor expenses. And I recognize that some of that is driven by provider transfers that are, distorting that. I also, in the narrative, it was a little bit unclear. In the section under labor expenses, there's a discussion about having, a wage analysis done, and it said that the wage analysis suggested that, the wages were significantly below market. Considering affordability, GMC implemented only half of the increases in fiscal year 22, deferred the remaining half to fiscal year 23. And then it said that the next paragraph talks about the expertise of the compensation consultant, suggesting that there's going to be proposed increases again, to catch up in the fiscal year 2024 budget. So I'm trying to understand exactly what the wage increases were, exclusive of provider transfers. I don't want that muddied in here, but just what were the wage increases for existing employees between 21, 22, 22, 23, and now 23, 24, just so that I can understand where some of this is coming from. and when they were implemented. Is that a possibility? If you have to follow up with that, Jen, that is totally fine. I'm just trying to understand what's in the narrative, where this 22% growth rate in labor expenses is coming from, apart from provider transfers. And so tracking that over time.
Sure. And I apologize. I really should have been a bit more clear in that statement. So what I really should have said was we incorporated the consultant's proposed 2024 cost of living adjustment of 4% into our budget. And if it helps, I can share the org-wide board member homes, if that helps. So in FY 2022, between market increases and a cost of living adjustment of 3%, that expense was $1.7 million in total. In FY 23, between the market increases, the remaining market increases that we mentioned in the narrative, as well as a 4% aggregate cost of living adjustment that we just did here in at the beginning of May, that was a $2.3 million expense. And then for the 4% increase in FY 2024, and this is for a cost of living adjustment, so unless the market moves again, we're hoping that we're remaining a bit static there. That expense is $835,000 in total. Okay. Hopefully that helps clarify.
It does. Even better. I apologize for that. Terms. So what was the market adjustment plus the cost of living in each year? So you've given me dollars and the cost of living for each year. So it'd be just helpful to understand what was the market adjustment plus the cost of living for each of those years, just so we can get a sense of how much catch up had to happen because of the market.
Oh, I can isolate the market, but I could definitely get that back to you.
That's great.
That was aggregate for both items. So I can certainly isolate the market adjustments and send that to you. Certainly.
That's great. And then my final question is, in I think most experiences, EMR's implementation always come with some productivity reductions. It's, it's sort of par for the course, it seems, when hospitals implement these big EMR shifts. And I'm just wondering how you've factored in, if you've factored in reduction in utilization simply because of the EMR implementation.
Great question. That does normally happen with an implementation. However, we feel that the operational efficiencies, because we're going from a lot of manual processes in the current EMR to more automated processes in the new EMR, we feel that's going to counteract any productivity decline that we would see in the FY 2024 budget. We feel pretty confident about that with the way we've built the new EMR.
Okay. All right. Well, thank you so much. Back to you, Chair Foster.
Great, thank you. I heard Member Lunge. Go ahead if you have some questions.
Thanks. Hi, Jen. Thanks. And Dan, thanks for joining us. I'm wondering if you could speak a little bit to your ACO participation in 2024, what you're expecting for programs.
We will be participating in the Medicaid and MVP programs that are offered through OneCare for FY24.
Thank you. And then also, I'm wondering how you are thinking about the Medicaid redeterminations and if you've included any budgetary impacts related to changes in coverage.
We've not included any assumptions regarding the redeterminations in this budget. One could estimate that we would possibly return to our 2019 percentages for bad debt and free care, but I hesitate to do that for two reasons, honestly, Board Member Lunge. One is the changes that we've been implementing with our pre-registration process that we mentioned in the narrative. That would certainly have a more positive impact for those particular patients. And the other item that we have was the way we were classifying our average generally billed discount prior. That was in bad debt instead of in the contractual line. So it was an accounting change that we did, and that would certainly have an impact. And the other thing, obviously, is I really don't want to run the risk of understating my net revenue and overstating my bad debt assumptions for something that's a bit unpredictable for us at the moment.
That makes sense. one thing I'm a little curious about in terms of the approach that we've seen in this area is there doesn't seem to be a lot of assumptions related to people moving from Medicaid reimbursements to commercial reimbursements, which certainly I think you wouldn't expect the entire population, but you would expect a little bit of that to some degree. So I don't know if you have any thoughts on that, Jen, but I welcome them if you do.
Yeah, not too much. Just in our experience thus far, it's been a couple of months here. When I have conversations with our financial advocate, it unfortunately has been in the other direction. It's going to self-pay. I think she maybe had one individual that she was able to see recognized going to commercial. It's a little early in that, I think, at the moment, but obviously we would like to see it going into the commercial bucket as well. But from current experience, just in the last couple of months in my conversations with her, it's really been going from Medicaid to self-pay currently.
Thanks. I think my other questions have already been answered. Thank you.
Good morning, Jen and team. This is Tom Walsh. I just have a question about the cost report. If we could go back to that tab, please, Sarah. Jen, it was very helpful, I think, as you explained, things like nursing education can be categorized in one bucket, allocated to one bucket for a cost report, and allocated to another bucket for a finance report. And I'm wondering if you could just help us understand, you don't have to go into any great detail about your particular organization, but help us understand how a finance team decides which bucket to place those kind of shared services that are not either directly administration or direct patient care. How do people decide where to allocate those?
Sure. There are some rules that we do follow from a cost reporting standpoint that we do adopt when we're classifying those as well in our financial statements. There's some variation, though, that happens among the hospitals, the one that I pointed out, obviously. And so you try to look at those at what is really directly associated on the clinical side and try to parse those out as best as possible versus those that might have dual purpose. So, for example, they have administrative duties, but also may have clinical duties, and try to isolate those two components of an FTE, so to speak, or salary. And that's how we do it here. We really scrutinize the difference between the two so that we can make sure we're putting it in the right place. And as you heard me mention, we continue. It takes some time when you're evaluating cost reports over the years to start just refine that and where those departments should actually be, and we've been making those necessary changes. But I think that really kind of sums up how we look at it and how we would want to classify those on both the income statement and the cost report.
Mm-hmm. So it seems that's excellent. Thanks. It helps me a lot. And it seems like each of the reporting requirements has its own set of rules that every organization would have to follow. But there are also areas where discretion is needed. And when, say, a regulator starts looking at one, it's only then that there would start to be a standardization among the facilities the regulator's looking at, because there's quite a bit of discretion allowed, if I'm hearing you correctly.
There is. I think, Sarah and I had sidebarred on coming up with maybe a more standardized approach for all of us to report, so that you're evaluating an apples to apples versus an apples to oranges, because that particular line on the cost report can also, I don't want to get too weedy, but there's something called a home office cost report. In my past, we have filed one of those, and it takes all of the overhead expenses from, let's say, a network structure, and puts them all in that line where there could be some clinical functions in that you would want to parse out. And I think, I'm happy to work with the staff as well in creating maybe a more apples to apples standard approach too. this. And I think there's definitely some variability when you're in a small hospital because you wear many hats. So, we do time studies so we can isolate some of that as well. But I think to try to mitigate that variability, we could maybe come up with a standardized approach for the hospitals to report.
Great. I hope we're able to take you up on that offer of helping create a standardized way that we could use across the state, because the different forms having different rules and still allowing for discretion is true across the country and is true with all the hospitals that make up the peer groups. So helping us create a standardized way within our state would be, I think, really helpful long term. So thank you very much.
Dr. Merman, do you have any questions or comments?
Yeah, I just have one quick question. Thank you both for the, well, there's more than two of you. All three of you so far have spoke for the presentation and submission. Mr. Bennett, I just had a quick question for you. I could go to either, I guess. With regards to the New England Alliance for Health group purchasing, does that also help you with insurance contracts and negotiations?
So we participate in NEA both in terms of our employee benefit insurances and also with our normal group purchasing supplies, that sort of equipment, that sort of thing. So we do get, we do have advantage of that purchasing power on the employee benefit side of things. And some of the business insurances, but not all of them. We don't go through them for all of our business type insurances.
But when you negotiate with insurance carriers, they're not involved in that process.
Oh no, I'm sorry. For our reimbursement, you mean?
Yes.
Oh, I'm sorry. No, they are not in for that. I'm sorry. I misunderstood.
That's okay. I apologize for the lack of clarity. Do you do that directly from Gifford with the carriers for reimbursement? Or do you have a in-between company that helps you with that?
Go ahead, Jen.
Yeah, I knew he was going to point to me. Yes, we do use a third party firm in that negotiation process. That doesn't mean that we don't have a direct line of communication with the payers either, but we do utilize a third party.
Okay, thank you.
I had just a couple on the labor. The number of FTEs went down pretty significantly, 287 down to 191. I assume that's mostly due to the provider transfers. And then the compensation per FTE jumped up fairly significantly around the same time. And I was wondering if you could speak to that. Was that because of the types of providers that were transferring out, or what else could you attribute that to?
Sure. I think there are two issues that are contributing to the opposing relationship that we're seeing here. One is that we moved a considerable amount of FTEs into our Gifford Shared Services division. Those were originally reported in GMC as well as our daycare. And so we did move those FTEs out of what we report for just the hospital. And I think that's a little bit of the distortion there and why you're seeing such a deep dive in that particular line. And then also, I think it's important to, from the salary line, that, staff vacancies would have an impact on this calculation also. We report actual FTEs in the calculation that we provide versus total position FTE calculations. So if we do have a higher turnover, which we do here at Gifford, in any of those mid to lower salary ranges, then that calculation of dollars on that upper line is actually going to look higher. So I think that's the reason we're seeing that opposing relationship there.
Okay. And then In terms of the anesthesiologists that you use, do you currently employ directly any anesthesiologists? And how has that number changed over the last few years?
Or Dan, you'll have to correct me if I'm wrong. I want to say it was last year or the year before. We are using a contracted service, similar to, as I mentioned, that OB hospitalist service that we're using now. So we do not have any employed anesthesiologists any longer, although the anesthesiologists that were employed with Gifford did transition to that organization. We've had some turnover with them over the last year or two. But in terms of us actually having that as an expense, it's in a purchase service line versus a salary line for the anesthesia service. And Dan, I don't know if you want to add anything to that.
No, I think that answered it. I think it's been 2 years. Is that correct, Rebecca? Yes. So it's been 2 years that we've had that service.
And I was curious how that has worked out from both, availability of anesthesiologists when you need them, and then in terms of the cost.
Rebecca, do you want to jump in on the, Rebecca oversees the contract and the staffing of that service.
Yes, thank you. So one of the big changes that was made over the course of time was we moved from an all MD service to a mixture of MD and CRNA, which has actually gone really well. As Jen said, we did transition all of the clinicians at the time over to the contracted service, and over time we have, replaced them with different folks as they've, moved on to different places. Most of our anesthesia providers live right here in our community, even though they're contracted providers, they live close by, or they stay in housing that we have here, and so they are still available immediately. We have a 20-minute time for them to come in, but most of them are here within just a couple of minutes. So they're still 24/7, and they're still available with us. We've had a really great working relationship with the organization, and we have a really nice open line of communication back and forth between them.
And have you found this to be a cost savings?
With the complement of providers that Rebecca mentioned, going from an all MD model to a combination of MD and CRNA, we did have a cost savings there. It was, don't hold me to this, but it was in the ballpark of about $500,000.
And this third party, is it just made up of anesthesiologists that used to work at Gifford, or are there others? And then it's a compound question, I apologize, but then the second part of it is, are they working with other hospitals or just Gifford?
We have the group that's here with us now are not necessarily, they're not all the folks who were here when we made the transition. And for the most part, the group that's here consistently only work here. We do have folks, which is the benefit of going with this organization, who float from other local hospitals when we have someone out on vacation or, some other type of leave.
Right. And can you speak at all to how many other hospitals they may be working with?
I wouldn't have intimate knowledge of that for each one of them, but generally speaking, it's one or two. So they're here and they're somewhere else. But they're not coming from all over the place.
But this particular group that we're contracted with works with a handful of other hospitals in Vermont and New Hampshire.
Can I just ask a follow-up question? Because I think I'm a little confused by the word group, whether that means, it sounded like, Jill, you were speaking about the people who come work at Gifford as opposed to the organization they work for. And then I think Dan was talking about, and maybe Owen was asking about, the group that the individuals work for. So can I just get a little clarification there?
So we contract with a third-party anesthesiology group. So it's a private company that employs anesthesiologists and CRNAs That group then contracts with hospitals to provide that service at their hospitals. And that company, that anesthesiology group, works with a handful of hospitals within the region close to us in Vermont and New Hampshire. Rebecca was noting that the individual doctor, anesthesiologists and CRNAs that work at Gifford may also work at one or two of those other hospitals that their company contracts with. And it just varies by their personal preference. Did I get it?
Yes, thank you.
Okay.
That's
okay,
that's what I thought I heard, but I just wanted to clarify so that it was
Yeah.
a little clearer.
Business is confusing.
I want to follow up on some of what others had asked about this retroactive adjustment to the charge master. Is it accurate that Gifford has not increased the gross charge on any of the services in 3 years? Is it 3 years?
Two. 20 starting in FY 2022, we were not able to implement that increase. We were hoping that we could implement that increase. We were originally supposed to go live with our EMR in July of this fiscal year in 2023. So we were hoping that we may, and we mentioned this in our hearing last year, that was our hope. Unfortunately, we did have to postpone our go live to October. So now we're 2 years of those increases we've not been able to implement.
Any of them?
Any of them. On any service line.
Right. And just so I'm clear, the issue exactly was, why couldn't you?
So there were two things that were creating this particular issue. One was we needed to completely rebuild our charge master. There was a lot of revenue code changes that needed to be implemented, location of service lines, and things of that nature. So we've completely rebuilt that, and we're prepared to go live with that, obviously, with the new EMR. And also we needed to implement, or not even implement, but undergo a price analysis and a price study of our current pricing structure. And we've also done that in tandem as we've been gearing up for our go live. And so those two things really have prevented us from implementing those price increases. We certainly don't want to, some prices go up, some prices go down when you do a price analysis. And I certainly wouldn't want to put that additional percentage on prices that we needed to reduce. So those two things were really why we were not able to do that.
Okay. And maybe somebody asked this, but what happens if the insurance companies don't agree to these increases?
Well, there's always a negotiation, obviously, between us and the payers. We do, without getting too much in the weeds of our contracts, there is language in our contracts that point to the approvals by Green Mountain Care Board. We have, in the last 2 years, as well as this year, have sought quite low price increase requests. So we are hoping that our negotiation with them will take that into account.
I don't know if you saw it, but I'd just point out for your awareness that the Care Board issued rate review decisions this year that said that the rate increases we allow in our hospital budget decisions are not an entitlement, and that insurers are required to negotiate based on affordability, access, and quality. Anyway.
I think if I could, Chair Foster, I do, those 2 years they were approved, obviously, by the board. And we wanted to be transparent in our budget and share with you that that's what we were doing. And, you know, it is a negotiation between the commercial payers and us. And so, you know, that is what we are seeking from them. But I understand what you're saying.
I appreciate that. And thank you for the transparency. I think it's really, it's really critical. And I want to point out that I really do appreciate the fact that you guys hit guidance 3 years in a row, which I don't know how many hospitals have done that, but that makes this job a little bit easier for us. The last question I had was about how physicians are generally compensated. And if you could speak to just the general methodology for compensating physicians. And one of the things I'm trying to understand is whether or not physicians are rewarded or incentivized for increasing revenue, either through increased volumes or increased procedures, or which types of procedures.
So we compensate, again, we're speaking about the specifically about the hospital. We compensate our physicians based on salary. So we derive a salary utilizing national surveys, and then we evaluate them. We evaluate our compensation salary portion of the compensation based on the national surveys. In addition to that, we do have incentive programs, and there's two components to that. The first one is based on looking at national surveys, looking at work RVU. So that is a productivity standard. So that's a component of the incentive. The second component of the incentive is what we call citizenship. And that incentivizes activities that where our providers are doing community outreach activities, where they are participating in medical staff quality type activities, things that promote the practices, things that promote promote community health, those sort of things. For both the salary component and the work RVU component, we target the median on the surveys.
And Mr. Bennett, is there a set split between the work RVU and the citizenship component of the incentive comp, or can that vary?
For the most part, there is a dollar limit on how much we pay out on that.
What I'm trying to understand is
it's about half and half.
Okay.
In terms of those incentives would typically be about equal, the amount that they were able to earn through that.
Right. Okay. So if the incentive comp, the median of the surveys you look at is $100, and a physician hits it 100%, 50% would be due to their RVU performance, and 50% would be due to the assessment of their citizenship.
So let me take that example and come back and try to explain it. So if the median is $100, you know, we would pay them somewhere in the range of $80 on the salary. And then they would have the opportunity to earn $10 for citizenship and $10 for work RVU.
I get it.
To get to that median, if 100 is the median.
Understood. That helps. Thank you.
Okay. I should have started with that. Sorry, that would have been
easier. No, I misunderstood. That was great. I don't have any other questions. Mr. Sutter or Director Lindberg, do you guys have any follow-up, or are you guys all set?
We're set, just again, testament to this being the second of 2 hospitals under benchmark, and just shouts outs. But the advocate may have some questions, as I see Eric has arrived.
Great. All right. I will turn to the healthcare advocate.
Thank you so much, and apologies for the sound if you can hear heavy machinery in the background. My neighbor has decided to restart construction, and in an odd coincidence, they work at Gifford, which made me laugh very hard this morning. And they're wonderful. Just in case.
So I just want to point out that that we had nothing to do with that.
No, I didn't think you did. It's supply chain's fault, and the fact that they didn't have windows. So again, I want to echo Sarah's comment that you deserve to be applauded for coming at or under guidance for now years. And that is a level, I think, the level of commitment to your patients and their pocketbooks that honestly is good to see, and perhaps should be heard across more of the system. So my questions are going to be for Jen, and it's really I'm trying to understand. And member Lunge asked about this a bit, but I'm trying to understand the change in booking of AGB discounts to bad debt. And I think correct me, Jen, or chime in. I think I think you're saying that if you had a self-pay person who is going to be charged AGB for a service, so say that service is $200 on the charge master, and AGB is 100, that then they come in and and they owe 100, regardless if they pay that amount or not, that the difference between the charge master and AGB, so that added 100, gets booked as bad debt. And I know this doesn't actually have an impact on the bottom line. It's important to me just because I'm trying to understand how to use free care and bad debt, right? So I'm not working at the bottom line level. I'm kind of in the middle of it, but I don't want to make false conclusions.
Let me see if I can kind of use your example, Eric, kind of adjudicate this the way we normally would in our organization. So taking that $200, let me back up to the bad debt versus contractual that I mentioned earlier.
Mm-hmm.
So we do automatically out of the gate give a 50% discount for self-pay patients on that $200 charge. So that $100 initial dollars used to go to the bad debt line. We now change that net we consider as a contractual adjustment right off of the charge. So that remaining $100, if the patient, for example, qualified for some free care, let's say they qualified for 50% of that $100, so then we reduce their portion, their obligation to $50. If they were not able to pay that $50 of their obligation after 120 days in conversations, trying to get them on payment plans, then that $50 we would transfer to bad debt.
Okay.
Does that help clarify it? It's more, there's reserves and things that we do from an accounting standpoint, but that's really the gist of how you're to kind of adjudicate that example you gave me.
And was that switch due to the change in GAAP accounting standards, so that where they were trying not to have so many ways of booking things by industry type, or was that something you guys took on, or a mix of the two?
It's a mix of the two, from the revenue recognition versus how we should be classifying that initial discount.
Okay. And so I understood, Jen, this idea of the problems of looking at looking longitudinally at bad debt because of this change. Now, but I'm wondering, if we look at the system as a whole, so not just Gifford, right? Is it reasonable to expect that we're seeing similar changes in accounting across time amongst internal to each of the individual hospitals? That it's kind of difficult to compare across hospitals too, likely?
I don't want to speak for others, but I think you would find that perhaps the majority of the hospitals probably classify it the way I was describing, but I don't want to speak for them, obviously. There might be a couple that here and there that are putting that to the bad debt portion versus the contractual line. But
So
I can only
we would need
my experience, but obviously, I just don't want to speak for them, but I would presume that that's the same structure that they adopted.
Okay. Okay, that makes sense and it's helpful. And then just one last thing from me, when you're talking about the 2024 budget and you're looking at free care and you're saying you're aligning that with historical trends from before and after or during continuous coverage, not after, because that's right now. But I'm wondering, had you thought about, or had you included in that, like what the effect of the implementation of Act 119 will be, and if your free care policies become more generous due to that? Because that's like a quarter worth of impact, right? July 1, July, August, September. Yeah.
Correct. We're moving in that direction now, Eric, to adopt what is stipulated in the Act 119. It will have an impact because it does change that threshold, because currently we're at 300% of population care, so that is going to change that. But obviously, we're going to adopt that. We're going to be looking at that because we've been waiting for our go live, and then really start to adopt that. Obviously, we'll meet the deadline. But to answer your question, it certainly will have an impact on the amount that you see in those two lines, just because currently it's under that threshold is stipulated.
Okay. Yeah, I think, what's interesting, and I haven't looked at Gifford's FAP in a while, but it seems like you probably also, in addition to the FPL changes, the limits, actually, I mean, it may not affect Gifford as much, but for some hospitals, the statewide criteria, instead of being put at the limited to the service area, is going to be a really big impact for some hospitals. Mm-hmm. I don't know if that works out for Gifford, but that's kind of, there's some things that are kind of way deep inside of Act 119 that may have a bigger impact. And I think, we should talk, or I think Mike probably sent you a letter, Jen, and we'll be rolling out a bunch of stuff going forward. But yeah, Act 119, it's weird how that played out. So you have to kind of look at it with a magnifying glass.
Right. And believe me, I've read through it a few times too, Eric, and we're happy to work with Healthcare Advocate on, the changes that we're implementing, or some, as you mentioned, that we already have in place, in terms of providing free care statewide, and not just within our health service area.
Yeah. Well, thank you so much, Jen. And again, thank you for coming in a way that conforms with the guidance.
Thank you, Eric.
Can I just ask a quick follow-up question on Eric's question? I'm sorry, I missed in the initial, the $200 charge that you give the 50% discount up front. Where did you say you put that in accounting? How does that?
It goes in our contractual allowance line.
And is that reflected in the Exhibit 9 in the budget submission?
Yes, that would flow through our contractual, and the two lines that we entered at the very bottom, we added the bad debt and free care. That would be net of that discount, but the contractual line would contain that discount.
So that first $100 deduction would go under free care?
That first 100 line would go under contractual allowances.
Okay, because I'm just trying to figure, there's not a contractual allowances on Exhibit 9. I'm just trying to figure out which one.
Oh, is that, I believe that might be the one that is just gross and net, Sarah, if I recall. Okay, so that doesn't have our detail. If you look at our income statements, there's a contractual allowance line that's a negative number, and that will reflect where that is hitting on the income statement.
All right, I'll read through that. Thank you.
Certainly.
I appreciate it.
I had a quick follow-up on the third party that negotiates the rates with the insurance companies. Is that Helms & Co?
Yes.
And if it's in the contract that the insurance companies have to pay the amount approved by the GMCB, why do you have to pay a third party to negotiate?
Not all of the contracts have that in there, and that's not the only thing that we utilize Helms for. We work with them to build what we call a matrix, so that we almost have a contract management type of methodology. So we can look at inpatient versus outpatient versus professional, how much we should be getting from each of those contracts. So they don't only do the negotiation, but they also assist us in creating the different amount of reimbursement by each service, by each payer. The other thing that Helms and Company also assists us with is anytime a payer makes a change to their policies, we do ask Helms to alert us of those payer policy changes. If we also notice that our claims may not be adjudicating in accordance with those contracts, we work with Helms to decipher, that delta that we might be experiencing and have that conversation with the payers as well, so that we can ensure we're getting reimbursed at the rate that we were contracted. So there's other functions that particular third party does versus just the negotiation. I hope that helps.
Yeah, it does.
And Chair Foster, I would just add to that as a small organization like Gifford, and I assume that the majority of the hospitals in Vermont are in somewhat the same boat. There's only so much bandwidth that we have to do some of these more technical activities. So it is more efficient, and in some case, we don't have a lot of other options but to work with some people who do this on a full-time basis.
And if I could, it's much more cost effective than it would be hiring an FTE for that additional set of services.
No, understood. Yeah, no, appreciate that very much. Okay, I have nothing else. I will open it up to public comment. Yeah, and I have to say, I've done a fair number of hearings now at the Care Board, and the only hearings I've never had a public comment on are hospital budgets, which I find so surprising. Every other hearing we have, there's so many public comments.
We'll probably get some Wednesday.
Right. Well, yeah. Okay. Well, be that as it may, I will turn it back to you guys for your closing statements, and thank you very much for your presentation and for observing the budget guidance.
Well, thank you, Chair Foster. I appreciate the opportunity to talk with you all today. And again, thank you all from your team for the work that you've put into this as well. I guess I would just conclude by stating that, given my opening comments, we wanted to stress the level to which Gifford is a community-focused organization. We do work with very closely with our community members to assess what the needs are in the community, and then with our leadership and our board and our medical staff and others to ensure that we are organizing our services in a way that can meet those needs. And we do leverage the relationships, both local and from a wider region, to meet those needs, as you've heard about both in my comments earlier, and then obviously with some of the other services that we contract and work with. So I just want to again thank you for the opportunity today, and as always, please feel free to reach out to us if you have any follow-up questions, and have a great weekend.
Great. Thank you all very much. We will adjourn until 10 a.m. So we'll be back at 10 a.m. Thank you.
Thank you.
just being delivered.
Sarah Lindbergh, are you back? Great. Do we have the Mount Ascutney team? Perfect.
Hello, can
Okay.
you hear us?
We will resume our hearing of August 18th, and next we'll be hearing from Mount Ascutney. Thank you all for joining us today.
Thank you for having us. Nice to see you again.
Likewise. I'll have Mr. McCracken swear in the Mount Ascutney team. You'll provide your opening statements, and then I'll turn to Director Lindbergh's team for their presentation.
So good morning, Chairman Foster. I'll get the question first.
I'm so sorry to interrupt. Could you tell me who said thank you for having us at your table and how to spell your name?
Win Brown, Interim CEO, W-I-N-F-I-E-L-D, Winfield Brown.
Thank you.
Hey, thank you. And I think if you don't mind, to the Mount Ascutney team, if you could, for the record, introduce yourselves.
So Winfield Brown, the interim CEO here at Mount Ascutney. David Sandville, CFO. And Andrew Garamy, G-A-R-A-M-I, is our financial analyst.
Great, thanks very much. I'll go ahead and swear you in if you would raise your right hands. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Great, thanks very much, and the floor is yours.
Okay, great. We just we'll start with Winfield Brown. He's our interim, and he's been here a couple weeks.
Yeah, 3 weeks as of today.
And so he's probably not going to be a active participant, so to speak, since he's still learning Vermont and Mount Ascutney. But I thought he would just mention who he is and where he's from and how he got here.
So Win Brown, week 3 here, as many of you probably know, Joe Paris, the longtime CEO here, has taken over as CEO of Cheshire Medical Center in New Hampshire. So I've joined the team working closely with Dave and company. I'll say that in my first 3 weeks, I'm very impressed with the team here. Very lean, very competent, very focused on the community, as I think you know historically. And of course, this is my first Green Mountain Care Board. I've heard a lot about it from other colleagues over the years, and so look forward to providing some benefit where I can. And I'm going to turn it over to Dave.
Okay, so we'll just roll through some slides here. I know you guys have been through the gauntlet for the last couple of weeks, and I've shared this with Sarah Lindbergh, so certainly you guys can circulate it, and we'll only hit the high points. Quick agenda. We did the introduction, and we're going to really try to spend some time on quality, access, and costs as it relates to our budget, and outline our requests and some of the reasoning behind it, and then whatever you folks have. I'm sorry, we have a fly in the room here. So go ahead. Keep going. So our mission to improve the lives of those we serve. And who we are. So we are part of the Dartmouth Health System. We are in the bottom left-hand corner of the slide, and our subsidiary, Historic Homes of Runnymede, is listed there as well. You'll notice, for those who've been seeing our presentation for the last several years, that there is a new box on this org chart, and that is Southwestern Vermont Medical Center, who recently became the newest member of the Dartmouth Health System. We focus on 3 things here: quality, cost, and access. And that is the driver for pretty much everything we do here. And so we've recently been awarded some recognition from Becker's Hospital Review, top recommended hospitals in Vermont, top Vermont hospitals for patient experience, and top Vermont hospitals for patient experience. And basically, I put the questions, the indicators that we scored very high on there. Additionally, we received an unexpected award from Press Ganey, which was just released a couple months ago. for the Human Experience Guardian of Excellence Award. And so we hit the 95th percentile for patient experience. So we're very proud of that. Next slide. We have a very strong quality department here. To be frank, we probably have more FTEs in this department than most critical access hospitals have. We really focus on the next patient, the next survey, the next situation. We've maintained our 5-star CMS rating for patient experience. We're annually in the top 15% in the country for overall hospital ratings. We've just engaged with the Dartmouth Health System for continuous improvement initiatives, which is a Press Ganey tool, and to provide constant monitoring and feedback on various aspects of the patient experience here at Mount Ascutney. We just recertified and reaccredited by the Commission on Accreditation of Rehabilitative Facilities, CARF. We're one of the smallest facilities in the country to have CARF certification. And we did it this year with an emphasis on stroke specialty designation, since we receive a number of post-stroke patients from Dartmouth Hitchcock. It's a 3-year accreditation. This year we also added CARF certification for our outpatient therapies program. And we have some of the highest rehab scores for the CMS measures, frankly, in the country, and certainly of the handful of CAHs who have a distinct part unit for CARF. We just also had our CMS recertification just a couple weeks ago. We literally had only one item to look at, and that was a wording change in a single policy. Everything else was scored excellent with 0 concerns. And again, it just speaks to our goal of being constantly ready for the next patient and the next survey, and not trying to cram every 2 or 3 years to get prepared for the next survey. So one of the things about our quality measures is they're strong pretty much across the board, whether it's radiology, it's laboratory, clinic related. We have strong measures consistently, and frankly, it comes with a price. We talk about all the time in Vermont, the 3 stools of healthcare: access, quality, and cost, all equally important. And sometimes we have to make decisions on how we prioritize those in the current environment. And so, just putting in quality standards, expectations, or initiating new programs, it takes management. There's data and analytics. We have mock audits. There's software usually involved. And so there is a real direct cost to engaging at the level we engage at for quality. Obviously, we're doing that for patient safety, but it also feeds into employee satisfaction, engagement, retention, recruitment. People want to know they're working for a place that cares about quality and safety for their patients. We, year to year, with the Dartmouth Hitchcock Employee Engagement Survey, we've been the top scorer in the system over the last 3 years. And our top item is that our employees feel that we're focused on quality and safety for our patients. Talk quickly about access. This is similar to slides we've used in the past. These are the specialties that we offer at Mount Ascutney, color-coded to reflect whether it's a Dartmouth employee, employed provider working here, it's someone that we employ, or we have some departments that are a combination. We've really not changed our footprint in this regard for many years. And so this is really what we're measuring access against, are these specialties. The last 2 years, our visit lag report, we've made a significant improvement in getting patients in the door. I wish we could say that we're doing an excellent job at all times in all clinics. It is a constant process of monitoring and managing, but we've made material changes and improvements to the statistics that we provide to the Green Mountain Care Board. So just like quality, if you want to improve access, it requires ongoing monitoring of clinic and ancillary productivity. We periodically monitor wait times. We look at the regional need. We're in an area where we have 3, arguably 4 other critical access hospitals that we bump up against, and obviously the tertiary care center at Dartmouth. And like the rest of the CAHs, we have providers who from time to time decide to move on, retire. And so we have to kind of look at how that affects all of our referral patterns and how we're managing patients. The other facilities have the same issues, so we have to periodically come up out of our hole and look to see what's going on in the area around us and what barriers are there for people receiving the care that they need. We identify those barriers and we make great effort to reduce, remove, minimize those barriers. Sometimes that's with staffing, sometimes it's with the provider complement, sometimes it's just changing hours and schedules of those clinics. And then we have a committee that meets every 2 weeks called SLAM, and that's Service Line Activation Management. So anytime we materially change a line of service, or we have something that's happened that we feel is untoward relative to access, we convene and determine how best to solve that problem. There were some questions with the Green Mountain staff this year regarding the walk-in services that we initiated almost 2 years ago. And so we've been removing people who would normally be going into the ER with low acuity problems and putting them into a walk-in clinic within our primary care confines to reduce costs for everyone involved, but also to provide the appropriate service in the appropriate location. And with all of these efforts to improve access, we're always talking about what's the return on investment? What's it going to cost us to improve the access for the patients? Cost. So this is the third leg of the stool. I've listed and generally consistent with prior submission information. These are the services that relate to cost management that we engage with Dartmouth Health System on a daily, weekly, monthly, annual basis. Many of these result in some significant reductions in cost as opposed to us doing this on our own. We actually get Dartmouth Health pricing as an affiliate. Dartmouth also runs a group called NEAH, and N-E-A-H, and NEAH is a buying group for not only Dartmouth and their affiliates, but also other regional providers in Vermont and New Hampshire. And so that's the first tier of discount. And if you're an affiliate for many contracts, we get into another tier of discount as an affiliate. So that's probably the biggest area of cost control relative to Dartmouth. There are a couple other items that were asked in our narrative and with the staff questions that were addressed, and we're happy to take questions on those. But we're also leveraging them for regional lab services, unified PACS system oversight from pathologists and reading radiologists. The CHNA, all of that gets done as a group and regionally, which I think is good for everyone involved, but most notably in pricing. And we'll just roll to the next slide. We're largely fixed expense as a critical access hospital, as low as 70%, arguably 90%, depending on what audit firm you talk to. I generally like to believe that we're about 80% fixed expense. Some of that is related to our conditions of participation with Medicare as a critical access hospital. There are certain services that we're obligated to offer and a minimum standard for offering of those services. The most obvious one is the emergency room, which needs to be open 24 hours a day. Go back, please. Sorry. Yeah. So staffing ratios, we look at those all the time. How many nurses, RNs do we have for every patient on the floor? What's our minimum staffing for the emergency room? How are we staffing the clinics? What do we need in ancillary services? So we're constantly looking to keep those as in control as possible, but the large percent of fixed expense really prohibits us from moving that needle too much. We largely provide community-based services. We don't have any niche services. We don't have subspecialty services here. We just provide what's appropriate for our community, and we do it as well as we can. We have monthly department P&L and FTE reports that are reviewed with department managers. Over the last 15 months or so, we've been shorthanded in finance, but prior to that, we had 3 or 4 finance people who would go out and meet with department managers, specifically the clinical managers, to ensure that they're managing their staffing according to volume and their expenses as well. Senior leadership goes through position control weekly. We have a kind of a catchphrase here: just because we budgeted it doesn't mean we're hiring for it. So whenever a job opens up, there's a position that needs to be posted. We analyze how is that department doing, what changes could be made as an alternative to hiring an FTE. And over the last 2 years, we've been a little bit more aggressive with partnering with other hospitals in the region to share staff. One example is respiratory therapy. We hired a float respiratory therapist. We float them back and forth between Valley Regional and Claremont, and here in Windsor to cover vacations and lessening our need for travelers. We have a nursing pool within Dartmouth Health that we can all draw nursing from, as opposed to travelers, saving everyone money. And we're constantly leveraging the Dartmouth Health system for GPO pricing and other purchasing items. One of the questions that came up from the staff, I just wanted to touch on it quickly, is that we have been migrating for a number of years towards the Dartmouth Health benefits platform so that we can offer one set of benefits for all affiliates in Dartmouth. And we're going to be live on that January 1st, which will be the start of the second quarter of our fiscal year. Apples to apples, our current offering versus what we'll be offering our employees in January was about a $250,000 savings with slightly better benefit platform. We also will be migrating our retirement platform January 1st, and we'll be offering our employees a better plan with better options, but also they'll retain about $200,000 a year because of reduced fees. Administratively, we won't save any money, but we'll be passing that on to our employees, which is fabulous. And then the 340B mixed use, which is our in-house pharmacy. Our savings working through the Dartmouth GPO programs for pharmacy and working with the manufacturers, we've been able to increase our mixed use savings on 340B from approximately 200 and change to we're annualizing about $440,000 in savings this fiscal year and ongoing. There was a question about the Valley Regional Hospital. What savings do we expect? And this is what we are projecting. If this were to happen, let's say September or October 1st of 23, we expect that we would move the needle about $700,000 here at Mount Ascutney over the coming months, and Valley would actually benefit even greater. Some of that would be them moving from a lower level of discount to a higher level of discount as an affiliate of Dartmouth. But we will have common oversight, common management, and we'll pick up some efficiencies there, as well as some more efficient staffing between the two facilities by sharing staff. So our request, as you know, we've asked for a 5.1% rate increase. I put the slide up that Sarah Lindbergh had shared last year and then updated for this year. The circle is obviously us. We asked for 5.1%. Our rate request year to year, you can see, is a pretty tight band. There's only 2 other hospitals in the state who have done a better job over this period of 6 years managing their rate increases. What's interesting about it is I listened to a couple of the hearings, and we're asking for 5.1, and as you know, we don't get 5.1. So the actual net increase that we'll be getting after deductions is about 2.4%. So Medicare, we're going to realize 2.4, Medicaid 1.3 of that 5.1, commercial will be about 3.4% of the 5.1, and self-pay is essentially 0. We do have an MPSR increase of 6.8% budget to budget. So doing quick and simple math, taking 2.4% off that, the remainder of our increase is 4.4 relative to volume and intensity of services. Capital, as I've said in prior years, Mount Ascutney seldom has a sexy capital project to talk about in our presentation. We're doing about $3.2 million in capital next year. Mostly facility improvement, mechanicals. I've highlighted our most significant investments for next year. Our CSR renovation and the equipment associated with that is really going to come to about $750,000, and that is a regulatory requirement that is not optional for us. And we've actually been trying to get that done for a couple of years, but with bandwidth and availability of contractors and whatnot, it's been impossible to get it done sooner. We have some rooftop units, some other major mechanical, and we do have a Dartmouth-initiated project, which is rebranding, wayfinding, signage, and all of that we'll be implementing in the next fiscal year. Of note, we've been underspending for capital, as you probably heard from most, if not all other hospitals, basically because of bandwidth and supply chain issues. But maybe the most important thing on this particular slide is we will be migrating to the Dartmouth Hitchcock IT platform effective in FY25, which means that we will be filing a request in FY24. And we anticipate that that's going to be somewhere in the vicinity of approximately $9 million. So this is what we're all here to do, right? This is what it all boils down to. Is functionally we've asked for a 2.4% net rate increase. Virtually 80% of our supply, our expenses are coming in with inflation increases greater than that. Travelers, benefits, and utilities have actually been favorable, and we're projecting them to be more favorable than they've been in the recent past, which is great. That said, everything else is going up much more than 2.4%. And this brings us to this slide, which is, we look at those 3 legs of the stool, and every year we have to kind of figure out how to thread the needle. Just from an operating margin perspective, we have to look at what the Green Mountain Care Board would like us to do. We have expectations coming to us from the Dartmouth Health System. We have expectations of our Board of Trustees, and we look at our own financial ratios and determine what we need to fund capital and whatnot going off into the future. And at the same time, we have to figure out what our investment is going to be in quality to maintain the quality that we've achieved, but also to incrementally improve it over time. As we mentioned earlier, access, same thing. We look at what's it going to cost to improve access for our communities to the care that they require and should and deserve. And then we also look at healthcare reform and what the likely changes are in the state of Vermont for that. And that's how we arrive at our request of 5.1% rate increase, 2.4 net rate increase. And we try to thread the needle where we come in reasonable in the scope of what's going on in the Vermont marketplace and hitting the other things that the state of Vermont feel is important, most notably access and quality. over our operating margin over time. I think it's kind of, I can't see that with the presentation here, but I think it's it was roughly 1% over the last 10 years, which I think is very reasonable. If we were in other states, we would be shooting for 2.5, 3 as a critical access hospital. Quick discussion on risks and opportunity. You've heard the healthcare workforce probably ad nauseum over the last 2 weeks. We have wage pressures. Not only do we have the same wage pressures as everybody else in Vermont, but we're also competing against our mother company, who's competing against Austin. So they also opened a new tower a few months ago, hiring hundreds of nurses and other support staff. And none of this helped the employment market that we're trying to recruit out of ourselves. We're still suffering from the great resignation / retirement, our aging workforce, cashing it in during COVID. We have an extreme housing shortage here in the Upper Valley, which frankly just got worse with Dartmouth's opening of the new tower. And of course, we're competing with New Hampshire hospitals and non-hospitals for back office staff who have a great deal more flexibility in New Hampshire to cover the wage increases than we do. A risk is the Valley Regional affiliation. That transaction is in the hands of the New Hampshire Attorney General, and Dartmouth, Mount Ascutney, and Valley Regional are in constant. Every week we have work to do in that regard for the transaction. We had hoped last year that we would have been closing on that July 1st of 23. Well, here we sit in the middle of August. And I would say we'd be fortunate to get a decision out of the New Hampshire Attorney General by the end of October. So now we're kind of hoping for a January 1st transaction date, but even that's a little risky at this point. Lastly, one of the other big concerns that I've voiced for many years in these hearings, as well as in other settings, is the reduction of dish payments that was made a few years ago. Is the gift that keeps on giving year to year. And the retail side of 340B, essentially those of us who are able to participate in 340B, that revenue has functionally been cut in half for us at Mount Ascutney. So the ongoing dependence on other operating revenues has come to roost. And so this also speaks to why we needed to ask for 2.4% net rate increase. Opportunities, well, Valley Regional also makes that one because there are some potential savings, efficiencies that can be garnered with that affiliation. Dartmouth is in a constant state of rational distribution of services in the region, trying to figure out where general surgery should be. What do we need for a urology complement within the system, within the region? We will continue to pursue every opportunity in DH integration, whether it's in the group purchasing world or in the sharing of services or support services from Dartmouth and staff sharing. Another opportunity going forward is we're a stable organization. We've been very predictable. Our Board of Trustees recognizes that. Dartmouth recognizes that. I believe that the Green Mountain Care Board recognizes that year to year we don't have a lot of fluctuation and a lot of change. And I hope that that's of value to you folks. In market share, we still receive about 26% of our business from the state of New Hampshire. We have another high single-digit migration from other Vermont service areas to us. I think it's a reflection of the high quality and customer service that we provide and our employee engagement. We are looking to improve some of the service lines that we've had for the last few years. Most notably, we lost our full-time urologist during COVID. And so we've kind of patched that together with locum services. But now we've been able to broker a deal. Joe Paris brokered it before he walked out the door. So we have about a half-time urology service. that should be good for the next few years foreseeably. We're engaged, and we've talked about this the last few years, of succession planning for our ophthalmology professional as he nears retirement. Regionally, and I mentioned this in the global budget meetings, regionally there are no ophthalmologists in Claremont, Springfield, Lebanon, aside from Dartmouth. And so we really, there's a need in the community. Dartmouth is backlogged. If you decide to go get a cataract procedure at Dartmouth, you'll be fortunate to get in the next 6 months. So thankfully, our current turnaround time is very short, but our focus is on our communities and our patients, and there is clearly a need regionally to expand that service. So we are actively recruiting, as we have been for the last couple of years. That's a tight market. So we're hoping that we can get somebody on the hook over the next couple months. We're also working with Dartmouth on a possibility of a joint recruitment where they would hire someone and we would split the time with them, which would help them improve their throughput and help us with meeting the regional need. And so that's kind of the high view of our presentation and trying to address some of the concerns that we were aware that you might have. And we obviously understand that there'll be a lot of detailed questions that you'll probably want to ask. So we'll tap out on our end as far as the presentation and turn it back over to staff and the board at Green Mountain.
Thank you very much. I'll turn to Director Lindberg and her team for their walkthrough of the benchmarking tool.
Good morning. Thank you so much for your prepared remarks. I think they hit a lot of what we had planned to touch on, so appreciate your preparation for that. So as you see, Mount Ascutney is above the benchmark. However, and we'll update this value now that we know the commercial portion, but the commercial rate would be 3.4%. So that's the commercial anticipated realized change in commercial revenue from fiscal year 23 to 24, assuming a 5.1 charge master increase. Of note, one, the green check is a good thing, regulatory compliance. So everything the board asked for was addressed on time and completely. So always appreciate that. That helps make for a smoother process. And we also see a trend here where the operating expense growth and NPR growth are very close. And that's a trend that I think tends to show up for organizations with longstanding management of their expenses to a high degree, to a very successful extent. So as far as that NPR benchmark, the 12.4 is above the 8.6. We don't have an official benchmark for the operating expenses, but we see that at 12. One thing I just wanted to give you an opportunity to talk about is in our conversations, Mr. Sandville, it sounds like you've been really trying to operate with a skeleton crew and trying to make do, and that some of the driving force here is really right-sizing the labor force for Mount Ascutney. Is that correct, or anything you'd say on that?
Yeah, it's you know, obviously nobody cares if the finance team is running short, and we're grinding our staff into fine dust. I'm sure this season you guys all can relate to that. Obviously, we're more concerned with the clinical openings. We've been running at 10% below FTE for as long as I can remember. I mean, well back into COVID. To put some perspective on it, and I don't want to be overly repetitive, but you know, a lot of things are connected, right? So we have competitive wages. We are not at the top of the market, but we are competitive. And with the wage studies that come out of Dartmouth and some of the others that we have access to, and what we hear anecdotally during the recruitment process when somebody applies for a job here and the same person applies for a job at Alice Peck Day in Lebanon. You know, while I'm taking that job, they're paying me $1 more an hour. You know, we've got some anecdotal information as well. We've got a great environment to work in. We have extremely high employee engagement scores for the last 3 or 4 years. We do a great job. It's a great place to work. And yet we have about 20, as we sit here today, we have about 25 FTEs worth of travelers in our organization. Historically, really up through the first year of COVID even, I think we were running at 3 to 5 FTEs at any given moment, going back as many as 10 years that I can account for. So this is a really awkward situation for us. We did the first year of COVID, generally people pulling doubles, and it was unsustainable. And so we've had to turn to travelers, far less than ideal. We've been creative to the extent possible. We've altered shifts. I introduced Baylor shifts into our ancillary departments as an alternative staffing, which brought some staff satisfaction and less burnout. But we continue to run tight. And in fact, over the last month or two, our acute and swing census, in fact, today it was running, we were at 24 out of 25 beds. So, we're running hot on the inpatient side the last few months. And so, just for maybe some of the newer members or staff, we work off a staffing ratio. So if the staffing ratio for that shift is 5 patients to 1 RN, every multiple of 5 works really well for efficiency, 5, 10, 15, 20, 25. When you cross over into the next increment, 6, 11, etc., you're very inefficient. But in order to meet the minimum threshold, so we have gotten creative with sharing staff between the ED and the inpatient unit, drawing people over at different times, or if one unit is running hot. We are very blessed to have a CNO here who will actually go down and do patient care and plug holes in the ED on weekends to minimize the impact of travelers and whatnot. And to be frank, I wish she would do less of that. Because what she has to do. But she's a hero. She's an American hero. So that's kind of how we're managing, and it's been a little bit ugly for the last 2.5 years, anyways. But we're maintaining our quality and keeping our access up. In fact, improving both.
Great. And speaking of sharing labor across state lines, I know that's not always a trivial exercise. Is that also a benefit of your partnership with Dartmouth and kind of navigating some of that mischief?
Yeah, the catch is you have to be licensed in both states, but with Vermont adopting the Nursing Coalition and Compact, that's made things easier. But respiratory therapy, RAD, laboratory, and we've already been sharing managers. Our respiratory therapy manager is shared between Valley and Mount Ascutney. Our laboratory manager is shared between Mount Ascutney and Valley. We have managers who do some time at Dartmouth and do time here, and so we've tried to figure out how to broker things with float staff for nursing, RT, and we're probably in negotiations every month on a new position. We just needed a half an FTE, and hiring for a half an FTE is ridiculous in this market. So we found out that Valley needed a half an FTE, and so we hired a full-time 340B analyst to help us claw back some of our lost 340B revenues. And they work half-time for us and half-time for Valley. They're very happy. Valley's very happy. We were able to do it as opposed to hiring an FTE and trying to find things for them to do. We also just did that with an emergency management lead. We were sharing that 50-50 with Valley Regional. So we were able to fill that position with a half an FTE versus a full FTE.
Thank you. In looking at kind of labor, I see the kind of decline, that great resignation / retirement trend that was starting to really hit in the post-pandemic years, and seeing, the per FTE growth, a little bit above the benchmark, but also you started quite a bit lower. So when I look at it in totality, you're down toward the bottom. So not seeing kind of any concerns from a staff perspective on the labor, and your growth is within the benchmark. Not necessarily ever concerned when utilization is over that benchmark, but I did notice that for fiscal year 22, your payer revenue really did not keep pace with the utilization change. And I think you've kind of spoken to some of those challenges. Just wanted to give an opportunity if there's anything else you wanted to flag related to that trend.
Yeah, I mean, there's kind of a couple key drivers in that. One is we had higher Medicaid as a percentage of business. Part of that was Medicaid extending folks coverage during the pandemic. But the other piece of that was just more people qualifying for Medicaid on an ongoing basis with the employment issues that they were dealing with out in the marketplace during COVID. The other thing is we took some hits on our provider complement relative to surgery. And last year for budget, we were conservative because the outlook for recruitment relative to urology, Dartmouth had pulled back their pain provider. We had a lot of incremental, I call it death by a million paper cuts, but it really hit the OR, and so the OR is one of the better payer mix departments within the hospital. So that kind of takes care of 80% of that discussion, Sarah.
We also had a lot of boarders at the hospital that year.
Yeah, thank you.
And high swing census versus acute.
Yeah, we had, I think we averaged something like 6 boarders for most of last year. We're thankful that as of this week, we're down to 4. And nobody over 6 months, or only one person over 6 months they just crossed. So.
Thank you. And I would just note that maybe people who aren't staring at these graphs as much as I would say that this very low consistent operating expense trend is unusual, and I think is a testament to some of your focus on those areas and might indicate some catch up that's going on in the current environment. So obviously you're a border hospital. So according to our data, which is certainly not perfect, about half and half in terms of who's coming from the White River Junction HSA versus from out of your HSA. But one thing that I just want to note here is this is one of the heaviest population mixes for Medicare. So, you see how low the bars are for Medicaid and commercial and how high they are for Medicare. So that's saying of all the dollars that were spent in the White River Junction HSA, most of those folks are going to be Medicare beneficiaries. And of those dollars, most of those are spent outside of the White River Junction HSA. Since it's dollars, that's probably generally some tertiary care, probably going to the appropriate facility across the border. But do notice that there's been a little bit more volatility in terms of the dollars over time, and just curious if you think that might be pandemic related or if there's other kind of trends in utilization and what you're observing.
Yeah, I guess, of all of the Tableau data presentations, this was the one that was maybe the most concerning from a just kind of what is it perspective. And the issue, and I break this up in many other state settings, the White River HSA is a horrible measure for us. So the biggest practices in White River Junction are independent. They are not affiliated with Mount Ascutney in any way. They refer to Alice Peck Day and Dartmouth, mostly Dartmouth, for ancillary testing, for surgeries, for inpatient stays. All that goes across the river. It does not come down to us. Once you get below Hartford, into Heartland, now, which falls into that, now you're talking about us, but really we bump up against the Springfield, and we're in stone's throw distance of Gifford. So the White River Junction HSA actually goes above White River Junction, and we don't even know who those people are. So we should, I've been complaining about this for 10 years. I don't know that I don't have a productive solution to offer, so I apologize for just ranting, but you know, really this is Dartmouth experience. This is Alice Peck Day experience at large.
Yeah, that's fair. Yeah, I do think that moving towards maybe a Dartmouth Atlas or another indicator that isn't so hung up on these state lines that patients maybe aren't would be beneficial. So I totally hear that. All right. And then everyone's favorite page is the cost report. Lots to say about what this is and isn't, but as far as we can tell from what we've got here, Mount Ascutney is somewhere, there you are, a relatively small critical access hospital among the peer group. And we see that I was a little bit surprised that your case mix index was as low as it is here in fiscal year 22, given your service mix. So just, is that, I mean, you're probably closer to this than me. Just wondered what your impression was of that indicator.
Yeah, so actually, if you could just move your cursor a hair. Yeah, thank you. So, you know, we went and actually looked at this to see how we were running this year versus last year. You know, our rehab are the highest case mix index because they're medically complicated and require a great deal of rehabilitative services. Swing bed is super low, and swing bed is essentially, I think rehab and swing are 75% of our inpatient universe, and swing is about 60% of that business, which is generally a case mix index somewhere between 0.75 and 1. You know, if you were to look at the range of case mix. So this actually tied out to what I would expect to see on here, pretty darn close, and it is what we're running this year. I think last year was 1.18, and this year we're running at 1.17. So it's pretty tight.
And that probably is a good segue to, you know, obviously this would be an outlier at the 29,000, but if this were a peer mix of other hospitals that primarily are doing rehab services, my hunch is that you'd be, if not at close to the median. I didn't have a chance to confirm that, but will. But so, just yeah, go ahead. I'm sorry.
Yeah, so you alluded in your question, your staff questions, that our inpatient service mix, it's the same issue as the last conversation, except it's more accentuated statistically. So Andrew and I went and just kind of looked at the FY22 cost report and looked at our discharges, and we did the math, and I tied within less than $1,000 of your number, looking at it in aggregate. So we're comfortable with that. If you look at rehab by itself, the number's more like 37 as opposed to the 29. If you look at swing, I think it was somewhere around 34 or 35. And so that's what's pulling everything up. If you look at our inpatient acute, which is, again, very small percentage of our business, you know, we fall within the range very easily. But as soon as you add swing, which are, you know, those are all multiple week stays for swing and rehab. You know, swing goes, we have folks in here, you know, now crossing the 6-month line. So not a lot of discharges with a lot of charges and patient days. So,
and yeah, excuse me. Yeah, and to your point about comparable critical access hospitals, there are less than 10, I think, distinct part rehab units with critical access hospitals in the country. So
yeah, if you could share that list, I think it seems appropriate to have a different peer group given your unique bimodal service situation.
I'm sorry, I missed that. Could you say that again?
Yeah, I believe there are less than 10 distinct part unit rehab hospitals, part of critical access hospitals in the country.
So critical access hospital is allowed to have a 10-bed distinct part unit, which is generally either a psych unit or an acute rehab unit.
Or OB.
Yeah. And so what you'll most prevalently see would be psych or geri-psych units. And especially with the Jerry site with the Medicare population, most CAHs have high Medicare population, as Sarah pointed out earlier. But to have an inpatient acute rehab unit, it's Wynn just commented that we're a bit of a unicorn, and that's definitely true. It is very difficult to manage the quality in a 10-bed rehab unit. So the people we compete with, so to speak, we don't have any immediately close to us, but UVM has a 20-bed unit. Rutland had a 10-bed unit, they closed it. Cheshire has a 20-bed unit. I think there's around 140 beds down in Concord, New Hampshire. There's some down in Nashua, then you're down to Spalding in Boston, and there's Maine Med has one in Southern Maine. So, but they're all much larger units. And so for us to be knocking CARF surveys out of the park compared to those folks is really a testament to our rehab director. It's a tremendous flagship service for us, but makes us a unicorn and creates us having a weird dots on whisker charts. So
and then we've kind of been over the limitations of this indicator. Any thing you want to highlight in terms of some limitations of this indicator that we're trying to get at?
Yeah, I was a little bit surprised by that, and to be frank, maybe it's worth a sidebar discussion after these hearings, just to see how people were reporting. I kind of laughed at some of the benchmarks who were running down at near zero and near zero. So they're a CAH part of some system, and everything's back office at the mothership, and they weren't counting anything, which is really impossible. But it would be interesting to see what people were putting in that bucket. I feel like when I look around at other CAHs, and with the exception of the quality department, we're pretty tight here. We have our billing department runs 2/3 of what most CAH departments run at. I mean, I just look at it's a handful of departments. It's not 100. It's maybe a dozen. And I look at that and what I know, and I've been able to look under the hood. I've had the privilege of being part of Dartmouth's integration work and performance improvement work in New London and Alspec Day and Springfield and Valley. And so I'm coming from Gifford fairly recently. I kind of know where everybody's at for staffing. So I was a bit surprised, but we can definitely clarify that.
Yeah, I'd appreciate your thoughts on improving that indicator, so measuring something that it matters versus maybe some just accounting noise.
It's a legitimate measure. I just think we got to make sure we're all reporting it the same, but I don't feel like we're egregious on there, but I understand the concern.
Yeah. For the cash available at the end of fiscal year 22, seeing, 44 million, knowing that that's maybe not all unrestricted, but, within the kind of middle 50% of the data. And then the only other place where you kind of are broaching the upper values is related to this earnings per adjusted discharge. From what you've said about the very high unit cost for your services, I'm guessing that's mostly what that is picking up on. But please correct me if I've got that twisted.
Yeah, I actually didn't do the math on this one, but my gut was exactly what you just described. So thank you.
Yeah, okay, wonderbar. All right, so cost coverage. So we see here that over time, Mountain Ascutney's got an unusual pattern in terms of the cost coverage for Medicare allowable costs. I'm guessing that some of this funkiness is going to be the unique services that you're providing, but also guessing your commercial population is very small. So some of that volatility is likely due to small numbers. Are seeing, again, less of a kind of downward trajectory, more of an even trajectory among the Vermont Medicaid payments, although we see that starting to creep downward from 21 to 22. providing generally a higher cost service, as you described, but the cost coverage, not really meeting that Medicare allowable cost for Vermont Medicaid, and that kind of being made up on the commercial side overall. So just don't know if you have any comments about this indicator, or if you think we're not getting the signal.
No, I think when I looked at that and I looked at the comparative, I actually do like the presentation. In looking at the comparative, I wasn't surprised by anything. I didn't feel like anything was way off. We clearly aren't getting cost on Medicaid, and we are all coming in at 99% as CAHs with the sequestration, basically. And I felt like when I looked at the commercial, I was maybe surprised by this graph at the variation, and because this is really a percentage of costs associated with those services, commercial services. So it's really not so much a demographic discussion. So I don't really know what my conclusion was when I looked at it, but it didn't feel wrong when I went back and looked at our revenue model and compared it.
Yeah, and I don't know if we've done this, but I just notably these have gone way down since fiscal year 17, and I just think if people didn't know that, that's an important thing to know. So as far as RAND, so again, I think this standardized price per inpatient stay is really just measuring the services you provide and seeing that on the outpatient basis, you're in that, near the 25th percentile. So think that this is mostly just measuring service more than price per se. And again, if you're able to provide those comparators, happy to kind of make sure we're doing you justice in terms of comparators. So that is all staff had. Happy to hear any other reactions you might have before we turn it back to the board.
If you could go back to the RAND data, please, Sarah. And what's interesting about this is I'll be curious to see how outpatient looks going forward, because we did our large price decrease, outside of the Green Mountain Care Board approval in 2020. So that was probably the better part of $2.5 million in ancillaries that we repriced in 2020, which obviously trickled into 21, 22. I think it was Jessica Holmes astutely asked in our hearing, are you going to be able to pull this off? Because we had a very low ask for a rate increase that year. I think it was 2. It might have been 2 and change. Or you're going to need to come back, and reset. And so we were able to, our estimates were accurate. And so we were able to absorb that decrease as well as continue on with a low price increase through that period. So I would expect that would get better in 21 and 22.
Thank you. Appreciate your straight shooting as always. Any other reactions generally before we turn it to the board for their questions, Mount Ascutney?
No, I think we're good here. Thank you.
All right, go ahead, Chair Foster.
Thanks. I'll open up to my fellow board members first if they have any questions.
I just have one, which is, could you speak, Dave, a little bit to your thinking around Medicaid redeterminations?
Yeah, so those, as I understand it, started rolling out in April. We have definitely seen a small change in our Medicaid percentage over the last couple months. I don't know that it's statistically valid, but we're seeing some movement on that. The beginning of this fiscal year, FY23, we liberalized our free care policy a bit. So we're trying to kind of glide path to next year's mandate, right? So we expect that the folks who are coming off the Medicaid rolls will migrate to commercial or free care or bad debt, kind of in proportion to where it has been historically. That's kind of the bet we made. We don't think it's all going to bad debt. We don't think it's all going to commercial. One of the issues is I don't know how the exchange is going to handle mid-year terminations. To me, this is one of the life-changing events that allow you to open enroll in the middle of the year is losing coverage. At least the way we offer our program here and most of the other employers as well. So we just kind of figured we're going to be spreading it based on historical, and it's not going to be overly radical for any payer group. That's our bet.
Thanks, Dave. That's all I had.
Thank you.
I have a couple questions if I can jump in. So a few things I picked up from your narrative and a few things from the presentation that I'd like to just expand on a little bit. And one was you talked about the telehealth services for emergency medicine and neurology. And I was just wondering if you could describe sort of the frequency those are used and the impact that they are having.
It's fairly low frequency. So it's, and it's when you need it, right? So I think telepsych has been the most utilized, and we utilize that in the ED as well as the inpatient unit. Neurology, we literally just signed up for that. So other than testing, we don't really have any practical experience with that. But it's been a help in a small hospital to be able to get a subspecialty consult on the fly with folks standing by. One of the things is Scott Rohde, who is the ED medical director at Dartmouth, used to moonlight up at Gifford when I was there, and he loved coming to the CAH to work without a net. That's how we refer to it. When you're at Dartmouth, you can get the kidney specialist, you can get whatever you need in short order. When you're at a critical access hospital, you are working to a degree without a net, and this reduces that and improves the outcome and the quality. And frankly, sometimes we're able to not have to transfer a patient because we find out that they can be safely managed locally and not put them through the rigmarole of being sent to Dartmouth.
Well, I think the other piece of it too is our ER in particular runs on APPs. So we don't have physicians typically in our ER, so we need some backup to provide them clinical expertise in decision-making and course of care. So that kind of thing, the telesupport in the ER in particular is supportive of how we operate.
I'll throw a caveat out because most people don't realize this, that those telehealth services are not billable. And mainly because of the complexity of the process and the credentialing. And in fact, when we just recently signed for the neuro service, I pushed back with Dartmouth a bit and said, we've got to push back a lot. Push back a lot. Okay, nobody at Green Mountain Care Board is surprised by that, but thank you for pointing that out. So I did push back a lot. I forgot I'm under oath. I should not exaggerate or minimize. And said, we've got to be able to bill for this. So Dartmouth is billing us on a per encounter basis for that, but we're not able to bill the payer for compensation, and they're not able to. And it goes back to for those of us who've been around a long time, the Nighthawk services for rad reads, right? There'd be somebody in Australia reading the MRI at 2 a.m. and would send back a read for the ER provider or whatever. And then the hospital, would bill for that because they enrolled that provider into their group. So we would write a check to the Nighthawk service, and then we would bill the payer. And that, wasn't always one-to-one, but it was pretty close and nobody complained about it. This service, the way it is designed and the way it is rolled out at this point is unbillable for anybody. So we're just writing a check on a per encounter basis. And it's well worth it for the infrequency and the need.
Okay. You talked about some volume changes associated with your walk-in clinics and avoiding patients having to go to the ED. Do you have any idea if you can quantify those at all?
Yes, it's approximately 700 people have been redirected from an ED setting to the walk-in setting, and that's only Monday through Friday for 4 hours. So we're actually been discussing just since Wynn got here about what's the appropriate expansion for walk-in, just because we took all those 700 patients out of the ED, and those were identifiable. Yeah, thank you for posting that graph. This is kind of what we've been tracking. So we talk about ongoing monitoring about services. This is kind of the stuff we do on a regular basis. So the ED was growing very quickly. A lot of that covers the COVID time period. And then you can see a big drop off in ED volume, which is the red line. And now you can see it's climbing up again. And the walk-in clinic is the light green, sage green, whatever, line on the bottom. And that's been trending up since day one. So we figured it would alleviate some of the staffing in the ER, as well as do the right thing by payers and patients and whatnot, and take care of the patient in the appropriate setting. And guess what happened? Well, the waiting at the Mount Ascutney ED is low. Yeah. So now we've got this organic growth back to the ED again. So now we're having to go back and revisit and say, well, now we have to expand walk-in to shunt some more patients over from the ED. But it's also a benefit. The walk-in's been a benefit for our primary care clinics as well, to take care of those same-day acute requests that come in, because that's what they do. They're set up to do that.
And we've had a challenge for primary care access. So it has allowed access for people who typically would get an urgent appointment with their primary care on any particular day, but there's no capacity in the clinic because we don't have enough primary care providers. So we're working on that. So it's in tandem with primary care, and it creates an opportunity in the future to bring some of those patients in to get a primary care with us as we bring on some new providers coming up.
Okay, and that 700 patients is what time frame?
A year and a half. Okay,
great.
Dave, can I just ask a quick follow-up question that relates to this? Dave Merman, yeah. I'm just wondering, one of the things that we've heard from primary care providers is that when there's a long wait times for imaging, whether it's referral lag or visit lag, that primary care providers will basically send their patients to the ED to get that imaging done. And I did notice, in the referral and visit lag, that you do have some wait times for some of these CT scans and whatnot. And I'm just wondering, could any of that increase, you've got primary care access concerns, but you also seem to have wait times for the imaging. Could some of that also explain some of the uptick in ED?
No, I don't know how to say this, so I'll just say it. You guys should be used to it by now, right? I would kill somebody if they did it. I'd be like, what are you doing? What are you doing? This is not how we do business. So no, so I'm unaware that has actually ever happened here, unless a primary care provider on call over the weekend when the clinic was closed needed a follow-up on somebody they saw during the week. That would be the only exception in my mind that would be acceptable here as a practice. And even that's, boy, that would be once in a blue moon. So now I have to go look, Jessica, when I leave this meeting and find out if that's happening. But we do look very tightly at the ED sources, and I get reports from radiology actually reports to me. So I look at all the referring providers and the sources of all the referrals every month. So I've never had any whiff of that whatsoever.
Okay, well, thank you. Looking at that data would be helpful, just to make sure. That sounds appreciated. Thank you. Back to you, Dave. Other Dave.
Hi. So one thing you kind of answered partway through from a question that came up that I've had, which is, you talked a lot about the savings associated with Dartmouth. Maybe if I was to sort of eyeball my memory of the presentation, $1.5 million, $2 million between shared savings associated with Valley Regional benefits programs, 340B. But as we know, there's costs associated with affiliation as well. And you talked about a $9 million IT upgrade that's going to occur here in the next 2 years. Are there other expected costs that you have that are associated with the Dartmouth affiliation?
Yeah, we have a shared service allocation that comes down for the services that they routinely provide for us, which, to your point, is standard affiliation. So you'll be seeing that with Southwestern. You know, right now we're the only Dartmouth, Vermont shop. So, you know, it's a little bit different for us than it is for the other affiliates on the New Hampshire side. But we do have a shared service allocation that we're not at 100% allocation, but we're going to be running somewhere probably around 600,000 and change, I would say off the top of my head, for the upcoming year. And it incrementally goes up as and sometimes it's offset by direct expense leaving our shop, you know, so and sometimes it's a half and half. Like for our IT staff, half of them are employed by Dartmouth and half of them are employed by us as we migrate to this platform. And so what we do is we take all of our direct expense, we send it up to Dartmouth, and then they reallocate it through the whole system. So I can't just take my share of shared services and then my own share of local. It has to be all thrown in the bucket and then dispersed by metric. So there's never a good way to do this. I've looked at some other systems. They're all doing it the same way to varying degrees. They might use different metrics, but to determine what everybody's fair share would be. But that will grow as we become more and more integrated. And the goal is that we're able to alleviate direct expense here to offset that as much as possible. That's kind of what we're trying to do here.
And gain access to higher quality services like cybersecurity.
Yeah.
Cyber.
We couldn't afford to provide the cyber security that Mount Ascutney enjoys as a critical access hospital. It would be just a ridiculous endeavor for us. So in that case, when we get a shared service allocation for cybersecurity, it's actually beneficial to us because we're getting an amazing product. And we're such a small piece of the system that we get a very small, disproportionately small allocation for that. So that one actually works for us both ways.
And where's the $9 million expected to come from for the EHR upgrade?
So it's at last, we're supposed to have an updated pricing actually this month by the end of August. Essentially, the short story is that going on to Epic, the EMR will probably be 3.5 to 4 million of that 9 million. And at this point, probably about 2.5 million for the HR and financial applications. Those are the two big pieces. And then there are some other smaller pieces and some infrastructure requirements, but that's the 80% of it.
And the source of those funds to pay for that?
So interesting you asked that. So if from an accounting perspective, we will be required to depreciate that entire project on our P&L. However, it will be funded 25/75. So we'll write a check for 25% of the 9 million, and Dartmouth will fund 75% of the 9 million. But the entire project will be required from an accounting principle to be expensed on our P&L.
Which is beneficial to us as a critical access hospital, recognizing the cost of the cost report.
Sure. Thank you. Thanks.
Couple questions from me as well. I'm wondering, one of the costs that you reference related to the transfer expense, you did a great job of articulating how much the loss has been for some of these patients that you are unable to transfer, once they no longer need a acute care setting, between, 2.7, 2.8 and $3 million a year in losses for unreimbursed care. And I'm wondering, we've heard from that there's going to be increased capacity of SNFs in the state. And I'm wondering if you've factored that in. Do you think that that will impact 60 new beds coming online sometime in the next year? We understand, trying to find more about that, but will that impact your ability to transfer patients? Will that have any impact on your net patient revenue if you can replace those beds with higher paying acute patients?
So the theory would be yes. So the problem is that some of the patients that we cannot place, they would be hard to place regardless of the number of SNF beds available. They have complicated social issues, behavioral issues, whatnot. So those are the ones that we truly call borders, because I wouldn't report on a border stat the person who had to stay 3 extra days waiting for a bed to open up at Genesis. We wouldn't really consider that in our discussion with you or even internally, because that's just the complications of doing business. But when we talk about these long stay patients, I don't know that 60 beds in Windsor would necessarily do anything but move the needle a bit, because most of the nursing homes, they're still understaffed like we are, so they have closed beds. Most of them now have payer percent caps, right? I'm only taking so many Medicaids. I'm only, so it's going to be a lot harder over time. I don't see any material change in that to speak of. It would be great to get a couple people out of here. We dog it. The care management team meets with me for an hour every Wednesday morning, and we go over every patient that could be a problem, is a problem. What are the barriers to getting them out? What creative solutions can we come up with to assist that process? It's pretty robust, and we're happy that we're able to move some of these patients. I'm not sure every other place would be able to, but we've been able to be as effective as possible. But what we're left with are near impossible to move to any setting.
So just as a quick follow-up to that, as we embark on this new Act 167 hospital sustainability work, and so there are going to be some recommendations that presumably will come out of that. We've been hearing from multiple hospitals about this concern about transferring patients and beds being utilized for subacute care, having a cost to the system. Is there a recommendation that you would make system-wide? For example, if you were pitching to the legislature, what would be your recommendation now to solve this problem? What do we need?
I think when we look at some of the geriatric site needs, we need to open some beds for that. Alzheimer's unit, those types of things. Those are the people that are just, no one can take them. So there's a facility in New Hampshire called the Ray of Hope, that we send the very complicated behavioral patients who would normally, if they didn't have the behavioral issue, would be a nursing home placement, but they can't because their behaviors, are really complicated and difficult. And so, they'll go up there and do medication management and kind of get them into the sweet spot of what makes them easier to take, and what medication regimen do we need to establish for this patient to make them more takeable. Those specialty, memory units, I mean, those are the types of things that I think would solve a lot of problems. As you guys have probably heard, the VNA has been running radically low in staffing, and now has reduced their footprint in New Hampshire and Vermont. So what we had some patients who would be, okay, you get them to a certain point and they can discharge home. They have some oversight, but they need some home health. Well, now we've lost a good percentage of that as well. So I would go with the specialty units would be my first recommendation. If you guys can take care of that for me, I'll call it good.
Well, I'm going to throw it right back at you for a second, because, you all are in this unique, interesting position where you're working on an affiliation with, Valley Regional. You're a part of a larger system, Dartmouth Hitchcock, and it's all of its satellite areas, where the system is constantly looking at the rational distribution of services and what the needs are. And you mentioned earlier that critical access hospitals have this opportunity actually to add on a geriatric psych component to their service line. So I guess my question back to you is, why doesn't Dartmouth Hitchcock writ large, the system and the potential affiliation, is this on the table to add a geriatric psych unit that would take care of this, for the rest of the state and presumably for Ascutney?
So I have been in meetings at Dartmouth over even the last 2 months where we've talked about what could be done. One of the fears that they had was opening this new tower, that we were just going to take all these subacute patients and fill the new tower, right? And they have the same problem we have, which is getting people out. And sometimes we're able to help them, sometimes we're not. But they have been discussing this. They have been speaking to their affiliates. They have been working with the local nursing homes. These are all things I factually can testify to. But setting up a distinct part unit is a level of complexity. There's a moratorium in New Hampshire on nursing home beds, right? Most states have moratoriums on adding new beds. So even with Valley, this has come up multiple times. They have an old OB unit that is largely unused. And so I've been involved in 3 meetings of what can we use that for? And of course, the Attorney General of New Hampshire, they're interested in how that resource of that space might be used. So those are real ongoing discussions. Jessica, if it were up to me, it would be done faster, better, but it's very complicated politically, especially with the affiliation and the AG looking at that.
As the cost report guy, I'll add a piece too. Distinct part units are generally a cost draw from critical access hospitals, so it reduces Medicare reimbursement. That's why there are so few in the country. So it will draw cost away from our reimbursement and reduce the margins.
Yeah, I think when we had the hospital-based nursing home, when I first got here, that was in the process of being unwound. And I think that was 22 beds or something like that here. Medicaid was adding a little bit to recognize the cost issue that Andrew just referenced, which was great. Grace Cottage got it, Gifford got it, Mount Ascutney got it. I believe those were the 3 at the time. But the nursing home took $2.4 million in today's money. Back then it was like 1.7, but $2.4 million off the table because it was attached to a hospital. So the hospital lost that much reimbursement so that the nursing home could lose money. So now the world has changed. 10 years have rolled by, and now there's a greater need for these nursing home beds with the aging population and all the things that you already know about. And to Andrew's point, not a lot of CAHs saying, sign me up for taking $2 million off the bottom line. But I will say that I developed a proposal that's being kicked around where if Dartmouth is able to fill a subacute bed or a bed with an acute patient versus a subacute, and subsidize the facility that's losing the cost, these guys stay even and Dartmouth puts margin up. So there is a play there. It's very complicated, but the problem is you can't get permission from the state of New Hampshire, which is where most of their affiliates are, to open a nursing home unit and add it and append it to the hospital. So it's just, I think it personally could be done, but it's a political hot potato.
Well, hopefully we'll have maybe more conversations about the possible solutions here, as this Act 167 work continues, and I'm sure you'll be tapped for your creative solutions. Let me just ask one final question, and it relates actually to the rational distribution of services that Dartmouth Hitchcock undertakes as it's considering all of these affiliations. Does Dartmouth Hitchcock use minimum volume thresholds to ensure high quality and low cost care? Are there minimum volume thresholds, for example, for orthopedics or for other types of service areas that are deployed when they're evaluating those rational distribution of services?
I'm very confident that that is used everywhere at Dartmouth, and even in primary care where there's no procedure minimum volume per year to maintain competency. But it's come up in our discussions about joint recruiting an ophthalmologist for the region. There is a minimum number of cataract procedures that you should be doing in your OR that not only maintain the competency and quality of the provider, but also the nurses and techs assisting them in the OR. So it's really a two-level competency. So I'm very confident to say yes, they are, and I know that they're doing it in primary care. I know that they're doing it in orthopedics. I know that they're doing it in general surgery. So I think it's an easy assumption that they're using it globally.
Fantastic. Then would you be willing to have them see if you'd be willing to share that with us? I would really appreciate seeing what those minimum volume thresholds are to ensure quality and efficiency in the delivery of care, particularly as we're embarking on this Act 167 work. So if they would be willing to share that, that would be super helpful.
Okay.
Thank you.
Welcome.
Any other board questions? Okay. I think I just have one really little set. On slide 19 of your presentation, you have the request, and then you have the various realization percentages, and then what I think in brackets is the net rate that you anticipate. Can you walk me through the math on these? Like why are you anticipating Medicare realization 47? Like where are these numbers coming from?
So out of the 5.1% increase, Medicare will recognize 47% based on our historical reimbursement rates. So 40.47 times 5.1 equals 2.4. So out of the 5.1, we're expecting to get 2.4. And Medicare typically recognizes 47% of our rate increase. And I know that that may slightly differ from what the staff has put together for you. I'm using a model that gets cut differently than how Sarah cuts the data. So I won't say that hers is wrong or that ours is wrong. It's just cut different. But it should be reasonably close to what the staff has produced. And so Medicaid pays 27% of that 5.1. So we realize 1.3% in our payments. Now, I will comment on the Medicaid because that was one of the questions and subjects that came up in our narrative, as well as the subsequent staff questions, is hey, did you guys book a pickup for Medicaid's improvement of professional billing? And so we are very happy that Medicaid threw some money at primary care and surgeries and specialties. That's great. Totally appreciated. However, we didn't get an increase for inpatient, outpatient, inpatient rehab, and certainly not swing. So when you look at this number, Chair Foster, you'll see that that 1.3 is assuming we were going to get something from Medicaid in all lines of business this year. So we've actually made a bet that's not going to be fulfilled. So we are actually, our expectation of Medicaid realization is actually lower than our model would project.
Okay, sorry, and I might be missing something, but So your change in charge request is 5.1%, and you're saying you're going to seek 5.1% increase, but Medicare is actually only going to give you 2.4% rather than 5.1.
Correct. That's when the dollars come in, it's going to be 2.4% on any given service with a 5.1% increase that was a Medicare patient.
Okay. And you may have said this, but where did the 47% number come from?
It comes from our historical run rate of reimbursement percentages. And it's not to the penny because we have anticipated cost report settlements coming in, and but it's pretty darn close, and it has served us well over the last 10 years of budgeting. We're seldom surprised.
Okay. And so then on commercial, if the care board were to provide a 5.1% increase, you're saying that historically you get 67%. So therefore, if we give you 5.1, you're going to get 3.4 in reality. That's what this is indicating?
Yes, that would be correct.
Okay. And then you had said, I think in your opening, that the net would be 2.4, and that's just taking all these numbers and weighting them, and that's how you come to the 2.4 net that you had represented.
Based on our historical service mix, what we budgeted for a service mix, our payer mix, what we're budgeting for a payer mix, and our historical reimbursement rates and other deductions like free care, bad debt. Yeah, we'll get 2.4 of the 5.1.
Okay. All right. So the free care bad debt impacts your realization rate that you're putting in here?
If you even look at our Yes, if you look at our P&L and take net patient revenue divided by gross patient revenue, it's going to be less than 50%.
Yeah.
And I don't think that's atypical for CAHs.
Okay. And so the 67% for commercial realization, that is not directly representative of how much you end up obtaining in your negotiations with insurance companies, is it?
That's based on our current terms. So if we had to renegotiate with a payer effective October 1st, and you guys agreed to the 5.1, which would seem like a great idea to me, then I would be negotiating with the payer to ideally maintain or maybe even hopefully improve, which like never happens in this day and age, but our percent realization.
Okay. And so is that because you have a negotiated discount off of change in charge with the insurance companies?
In a couple cases, but mostly not.
Okay. Okay.
Chair Foster, could I ask a follow-up? Please. I'm still a little bit confused. So if my organization made $100 last year and I applied for a 5.1% increase to my regulatory board and it was granted, am I to understand that the extra $5 that I made that year, 67% of those new $5 would come from commercial payer sources?
No.
Okay.
If you were billing us, I'm going to try to take your example and change it slightly. If you had an X-ray that you were billing for and it was worth $100, right? That was your billed amount, gross charges, and you sent it to Cigna. Let's say Cigna paid the average of our commercial realization rate. Then Cigna would send us $67, forgetting about copay, deductible, out of pocket. Then next year, the Green Mountain Care Board approves your 5% rate increase, so that X-ray is now $105. depending on the length of the contract that's hanging out there and the type of contract, right? Let's say that the Cigna wasn't being renewed and it was a standard percent of charge, then they would pay you 67% of the 105. So let's call it 3 and change. So last year you got 67. This year you're getting 71.
Yep.
Does that make sense?
Yes. Yeah, we talked about that with hospitals last